Hi, everyone. Welcome to our master's essay presentation session today. We are at Wednesday, May 6th, so this is our second round of presentations. Thanks for joining us last week, hopefully, and also joining us next week. But today we have five great presentations. It's going to be a packed agenda with five presentations. Each student will take about 10 minutes to share their results from their master's essay, and then we'll have about 5 minutes after each student's presentation for Q&A. So if you have questions and want to drop them into the chat or come off of mute, we really welcome that engagement. So I'm going to just go ahead and get started and introduce our first presenter, who is Dalila Saiyed. She is in the maternal, fetal, and perinatal health area of interest, and she came to the program with a Bachelor of Science from the George Washington University with a major in neuroscience. And today, Dalila is going to present about the epigenetic effects of intimate partner violence during pregnancy. So Dalila, I'll hand it over to you.
Thank you so much, Sally. Let me just play. My cat also might make an appearance, just an FYI.
I saw his tail earlier, I think, or her tail.
Her so yeah. So just like Sally said, my name is Dalila, and this is my master's essay on the epigenetic effects of intimate partner violence during pregnancy on mothers and offsprings. So I'm sure as public health professionals, we know what intimate partner violence is or have heard of it in our classes, but just as a refresher, intimate partner violence is the abuse or aggression that occurs in a romantic relationship. It's also the most common form of gender-based violence, and this includes physical violence, sexual violence, stalking, and psychological stress. The CDC reports 41% of women and 25% of men have experienced a form of IPV in their lifetime, and it can start as early as adolescence, which is referred to as teen dating violence. And 16 million women and 11 million men have reported experiencing IPV before the age of 18. Across demographics, rates are 2 to 3 times higher among Black and Hispanic women compared to white women, and IPV also results in adverse mental and physical health outcomes, such as substance use disorders or depression. So intimate partner violence during pregnancy, it's a sensitive time period for fetal development and is a window of vulnerability for the fetus and the mother. For example, neurogenesis, which is when new neurons are produced, can occur as early as 42 days after conception, and the prenatal period is extremely sensitive to environmental factors. And IPV serves as a chronic psychosocial stressor. As mentioned before, pregnancy influences maternal health through hormonal changes, which results in differences in stress physiology and immune function changes. And this is mainly through the hypothalamic pituitary adrenal axis, which is a primary neuroendocrine regulator that connects the central nervous system and the endocrine system for stress homeostasis. So during pregnancy, HPA axis is a key regulator of fetal maturation and timing of delivery. On the image on the right, during the non-gravid HPA physiology, which is during non-pregnancy, there is a negative feedback loop that occurs. A stress response triggers the hypothalamus to release CRH, which is corticotropin releasing hormone, which then triggers the anterior pituitary to release adrenocorticotropin hormone, which then triggers our adrenal cortex to release cortisol, which is our stress hormone. And then you can see that it negatively feedbacks on the ACTH or the CRH, which means it turns the stress system off. But during pregnancy, the placenta actually has a positive feedback loop on cortisol. So there's more maternal cortisol, and that can cross over to the fetus through the placenta. And that takes us into epigenetics. So what is epigenetics? It's the study of how behaviors and environmental factors can cause heritable changes in gene expression without altering genetic code. So it's different than genetic factors because it's reversible. And studying epigenetics can help us have a deeper understanding of the biological mechanisms that occur with the adverse health impacts of IPV. So IPV has been previously associated with epigenetic modifications in genes, such as the glucocorticoid receptor, insulin-like growth factors, brain-derived neurotropic factor, and complexin 1 genes, which are all involved in stress homeostasis. And epigenetics is usually studied through DNA methylation, histone modification, and non-coding RNA, usually through DNA or RNA samples from blood, saliva, or tissue biopsies. So I did a structured literature review using PubMed, Embase, and Scopus with the help of Hopkins Welch librarians. Search terms included intimate partner violence, epigenetics, and pregnancy. Studies were only included if the exposure was IPV during pregnancy or if a form of IPV, such as sexual abuse, was explicitly stated to be done by an intimate partner. So if they weren't during pregnancy or weren't explicitly stated that it was done by an intimate partner, then they were excluded. They were only included if studying epigenetic effects and not genetic effects. Animal and human studies were included, and there was no exclusion based on country, race, or period. So out of the 269 studies I found, only 4 studies met the inclusion criteria. 2 studies used maternal IPV as exposure, and 2 used grandmaternal IPV as exposure. 3 studies were actually from the same cohort, but they studied different outcomes. Whole blood and saliva were used, and 3 studies measured IPV before, after, and during pregnancy, and 1 measured during pregnancy only. So the 2 that studied maternal offspring effects, the first study found significant associations between maternal exposure to IPV during pregnancy and the GR promoter gene methylation and the offspring from whole blood of children. And this blood was collected from children 10 to 19 years after birth. They found that there is an association of hypermethylation in the GR promoter region, and this gene is a major regulator of HPA axis, and hypermethylation would result in a reduced expression of GR, which means that the stress response would be dysfunctional. In the second study, and also this study was the only one that looked at IPV and maternal methylation, and they found that there was no significant association, regardless of if IPV occurred before, after, during pregnancy for the mother. The second study found that 31 CPG sites, which is cytosine, phosphate, and guanine sites, which are important for IPV regulation, found that they were significantly differentially methylated, and these were located in genes involved in stress regulation, HPA axis function. And the multi-generational effects, both of these studies used saliva samples from the grandchildren to look at the IPV exposure. So I'm sorry for my cat in the background. 5 CPG sites were significantly associated with grandmaternal exposure during pregnancy, and these were located in genes such as CFTR and corrin, which are involved in circulatory and developmental processes. And the second study looked at DNA methylation in saliva samples, which showed significant association with grandmaternal gestational IPV exposure. And those genes were corrin, BARX1, and CLPX, which are important for developmental processes, mitochondrial function, and stress homeostasis. This study also looked at a stress physiological response, which was heart rate variability, and that is basically how our body adapts to stress. And they found that grandchildren who had grandmaternal exposure during pregnancy, that they had a lower baseline heart rate variability, which means that their body is in high stress and low adaptation mode. They also found that when they tried to recall a traumatic event, they had a more exaggerated stress response, and this was associated with increased DNA methylation in the grandmaternal exposure during pregnancy group. So from all these 4 studies, prenatal IPV is associated with DNA methylation changes in offspring, with HPA axis as the most common pathway, and there was evidence of long-term effects like the heart rate variability and significant association when the exposure was IPV during pregnancy. However, there are a few limitations. From the study themselves, there was a small sample size. They also used retrospective data when asking the women if they experienced IPV during pregnancy, which could lead to recall bias. There was some heterogeneity across these studies, such as different statistical measures, different biospecimens that were used. And also outside of these studies, there is a fear of retaliation for the pregnant women. They might not feel safe enough or comfortable enough to tell a provider or anyone that they're experiencing IPV just due to consequences that might occur. And then there's a lack of research in this topic, as my literature review only found 4 papers, and that leads us to future directions. The hope is to have an implementation of large prospective studies in order to hopefully find a more efficient causal mechanism between IPV and epigenetics, and a standardized protocol for IPV assessment to reduce heterogeneity across future studies. Also, there should be more demographic and nutritional factors to be included, as a lot of these papers didn't account for things such as race or folate intake, and that would just provide a more comprehensive look and understanding at IPV during pregnancy. And then the end goal is to always hopefully translate these findings for future prevention and intervention strategies in order to reduce the adverse health impacts of IPV during pregnancy. These are my references. Thank you. And thank you to my reader, Dr. Hong, my advisor, Carolina, and all my PFRH friends and colleagues.
Great job, Delila. Thanks so much, and perfect timing. I will open it up for questions. We have about 4 or 5 minutes for questions. Well, I'll go ahead and ask I'm interested more in the study methods of the studies that you included, and it seemed like maybe 3 of the 4 studies were all from the same cohort, and just like wondering about like the length of time that people were followed, and could you just talk a little bit more about that?
Yeah. So it was, I know 2 studies were done by the same author 2 years apart, but one study just looked at DNA methylation only in mother and children, and they also looked at the resilience in mental health. And then the 2 years after that, they looked at actually grandmaternal exposure and grandchild exposure, so that was different. And then the third study was actually done last year by a different author, and they also looked at grandmaternal grandchild exposure, but they had the stress response added to it. So they kind of just built on one another. I'm not sure how long the follow-up was, but I
Yeah,
know
so
that,
were they collecting it was retrospective studies, right? So they were collecting the information about IPV exposure like at the same time that they were maybe interacting with the infants and collecting the sample.
yeah, yes, I believe so, especially the first study. I think the other 2 studies in 2019 and 2025, they just went back and used the saliva samples that
Right.
the first study collected from the grandmaternal and maternal and the child offspring.
Thanks. Any other questions? Yes, Dr. Hughes.
I mean, please. Um, it sounds like this is just sort of a general comment. This strikes me as a really important research area that has not been studied very much. So kudos to you for identifying it and describing these studies clearly. But if it's possible to use, the banked saliva, for example, and data, did you think there's based on your knowledge of the literature, do you think there's plenty of scope for doing this type of research without having to collect new data? Um,
I'm sure there is. Then that brings up a good point that 3 studies, 3 people were able to use that saliva sample.
yeah.
Um, I'm sure studies can be done, but I think that also brings up there might be differences in maybe blood versus saliva, and people, and then
Uh,
maybe potentially women don't want to give blood or they
right.
don't feel comfortable sharing. So that's a question. I don't know what's the difference between saliva and blood,
Yeah.
but but yeah, that brings up a good point.
Yeah. Well, I was just thinking that it's a way of sort of jump-starting the literature, right? Because it's so important. And a lot hasn't been done. Stuff can be done with stuff. Studies can be done with already existing data. It's always a boon. So just a thought. Thank you. Really, very interesting. Like I said, really important study. So,
Thanks so much, Dalila, and thanks for showcasing your neuroscience background in this presentation as well as your public health expertise.
Thank
All right.
you.
and your cat's impressive interest in this topic.
All right, so we're going to go on to our next presenter, Alexandria White. Lexi is in the child and adolescent health area of interest, and she came to our program with a Bachelor of Science degree from William and Mary with a major in kinesiology and health sciences and a concentration in public health. And today, Alexandria is going to talk about infant and young child feeding and emergencies in high-income countries. I'll pass it over to you, Alexandria. And
Hi,
we are,
sorry,
yep,
I
there you go.
can share it.
It looks good.
Okay. You see the slides?
Yep.
Okay, great. Okay, so good afternoon, everyone, and thank you for the opportunity to present my research on infant and young child feeding and emergencies in high-income countries, a scoping review of preparedness and response to natural hazards using the socioecological model. So, infants and young children are among the most vulnerable populations because of their unique nutritional, physiological, and developmental needs. And in the first 2 years of life, adequate nutrition is critical for growth, immune function, and survival. And breastfeeding plays an especially important role, not only as a source of optimal nutrition, but also in protecting against infectious disease. Natural hazards such as storms, earthquakes, floods, and tornadoes are events that can cause harm to people, property, and the environment. And during emergencies caused by these events, the systems that support safe infant feeding are often disrupted. Families may lose access to clean water, healthcare services, and social support networks. And as a result, breastfeeding may be interrupted and reliance on formula feeding can increase, which can often be under unsafe conditions and can raise the risk of infections like diarrhea and respiratory illness. So there are established global frameworks to support infant feeding in emergencies, including the WHO International Code of Marketing of Breast Milk Substitutes and the Operational Guidance for Infant and Young Child Feeding in Emergencies. And these set out clear recommendations to protect and support safe infant feeding during crises. But despite the existence of these frameworks, implementation has historically been inconsistent. The study also builds on earlier work by Huang et al., which identified persistent gaps in policy integration, workforce training, and breastfeeding protection across both middle and high-income countries. And since then, climate-related disasters have continued to increase in frequency in high-income countries, yet there remains limited updated evidence on whether there have been improvements in how well these systems are prepared to support infant feeding during emergencies across different levels. And so to address this gap, our objective is to evaluate recent peer-reviewed evidence on infant and young child feeding and emergency preparedness and response for natural hazards in high-income countries and map it across policy, organizational, community, interpersonal, and individual levels using the socioecological model. To address this objective, a scoping review methodology was used following established guidance from the Joanna Briggs Institute and reported in accordance with PRISMA scoping review guidelines. For databases, PubMed, Embase, CINAHL, and Scopus were searched for peer-reviewed studies published between January 2019 to January 2026. And the search strategy combined terms related to infant feeding, such as breastfeeding and infant nutrition, with terms related to disasters, emergency context, and natural hazards, including hurricanes, wildfires, earthquakes, tornadoes, winter storms, and floods. Studies were included if they focused on infants aged 0 to 23 months, caregivers, or lactating women in the context of natural disasters in high-income countries. Only empirical studies were included, and we excluded studies related to pandemics, conflict settings, and non-peer-reviewed literature. Covidence was also used for review management. And so our search yielded 1,012 articles, and after deduplication, we landed on 764. After screening 764 records, 11 studies met the inclusion criteria following abstract screening and a full text review. Data were extracted using a table and analyzed descriptively, and findings were organized using the socioecological model, which enabled examination of influences across levels. So across the included studies, 5 studies addressed policy level barriers, 8 addressed organizational level barriers, 5 addressed the community level, 4 addressed interpersonal, and 6 addressed individual level barriers, with several studies spanning over multiple levels. And a total of 11 studies were included, representing 4 high-income countries: the United States, the United Kingdom, Australia, and Italy. And these studies examined a range of climate-related disasters, including hurricanes, wildfires, floods, earthquakes, and tornadoes, and used both qualitative and quantitative designs. Sample sizes ranged from 6 to 2,448. And so at the policy level, infant and young child feeding in emergencies was often absent or not clearly defined within disaster preparedness frameworks. Across the studies, there was frequently no designated responsibility or operational standard for implementing infant and young child feeding and emergency guidance into policy. Gribble et al. Discusses this, noting that in Australian emergency planning, no agency at federal or state/territory had designated responsibility for infant and young child feeding in emergencies. Broader structural barriers in high-income settings, such as the absence of paid parental leave and limited coverage for lactation support services, also contribute to these policy-level gaps. At the organizational level, practices were frequently inconsistent with infant and young child feeding and emergency guidelines, including inappropriate formula distribution and limited breastfeeding support within hospitals and emergency shelters. For example, Giusti et al. Talked about this and wrote, infants' products, including infant formula, were actively distributed into the camps to pregnant and lactating women, even without a specific clinic indication. And these camps were also described as having poor living and shelter conditions, which further complicated safe infant feeding practices. This was accompanied by limited training and awareness among healthcare and emergency staff, contributing to inconsistent application of infant feeding guidance. Access barriers, including service disruptions and staffing shortages, further limited families' ability to receive appropriate support. These challenges were not evenly distributed, with clear rural-urban disparities in access to organizational support, as rural areas often face greater difficulty accessing healthcare services and infant feeding resources during emergency compared to urban settings. At the community level, skilled support networks and hotlines were able to provide important guidance for infant feeding, but access was uneven with major geographic inequities. Again, rural populations in particular often faced isolation and poor access to services and safe shelter conditions. As highlighted by Group Essex and Durban, rural communities exhibited more social vulnerability and less resilience should a disaster strike. At the interpersonal level, support from family, partners, peers, and healthcare providers was critical for sustaining infant feeding. And when these networks were disrupted, caregiver stress increased, while one-on-one care was shown to improve feeding outcomes. And at the individual level, caregivers often experienced high stress, fear, and disruption to feeding routines, sometimes compounded by misinformation, such as concerns about milk safety. Despite this, many demonstrated strong resilience and adapted their feeding practices in response to the challenging conditions. So, all in all, at the policy level, infant and young child feeding in emergencies remains poorly integrated into emergency preparedness frameworks in high-income countries with limited embedding into planning or operational systems. At the organizational and health system level, responses are fragmented and reactive, shaped by structural and workforce constraints that lead to inconsistent delivery of infant feeding support. And at the community and interpersonal levels, support networks can help buffer these gaps, but access is uneven and not all caregivers are able to benefit equally. This review is limited by a relatively small number of peer-reviewed studies, many of which include small and heterogeneous samples. Much of the evidence is retrospective and based on self-reported data, which may introduce recall and reporting bias. Also, not all high-income countries are represented, limiting the overall geographic scope. And the screening process was also conducted by a single reviewer, which may increase the risk of selection bias. But despite these limitations, the review has several key strengths. It follows established JBI scoping review methodology. A comprehensive search was conducted across multiple databases, and the review focuses on a recent time frame from 2019 to 2026, capturing the most current evidence since the last major review. The use of the socioecological model provided a clear framework for organizing findings across different levels, and the inclusion of studies from several high-income countries offers a broader international perspective. So, in conclusion, progress since the prior review by Huang et al. Appears limited, with systems in high-income countries still largely fragmented and reactive in their approach to infant and young child feeding in emergencies. This highlights the need for stronger policy integration, improved workforce training, and coordinated multi-level strategies across the socioecological model, alongside approaches that are tailored to different types of natural hazards. Overall, the key message is that strong, coordinated systems are essential to protect infant feeding in emergencies, and these systems need to be clearly articulated across all levels of response to strengthen preparedness in the context of increasing frequency of natural hazards. And so I wanted to thank my reader, Dr. Cecilia Tomori, and the librarian who helped me, Lori Rosman, for assisting with the search strategy. And that is all I have.
Great job, Lexi. Thanks. And again, great job staying on time. We have, again, 4 or 5 minutes for questions. I see Isabella asked a question. So in your search, did you see any examples of policies that were successful in promoting infant feeding in emergencies?
Um, Honestly, not really. It was really like there's nothing really out there. And it's really disheartening. Um, But yeah, I mean, like there's the guidance that's global, but no one has really incorporated that into real policy. Yeah.
Thanks. Yeah, oh, go ahead, Emmy.
Well, my question was sort of a follow-up on that. I was just asking you to stretch a little bit because your literature review had a different focus, but what do you think might be the most efficient way or a practical way of trying to improve implementation of these guidelines and sort of across the board?
Yeah. I think that a really good start is my review or reviews like this that target like where the need is. And to really like bring that to light because I think a lot of what is out there is kind of just like more general. And so I think that once people are more aware of like what's wrong and where that is and like in specific like specifically in different systems, then we can at least have more conversations that will bring about actual change hopefully in the future.
Yeah, it struck me that, I'm thinking I could see how this would just be like, people just not even thinking about it, right? It's like we gotta shelter people, we gotta do this, and I'm not saying this very clearly, but just not sort of rising to the level of people's consciousness is this is something really important that we need to focus on. It's different than, making sure that the rest of the family has meals and so on. So anyway, really interesting. Again, a interesting choice of topic that is overlooked.
Yeah, thanks, Lexi. Thanks for shedding light on this yeah, very important topic that I have not thought much about. So great job. Um, and congrats. So we'll go on to our next presenter, who's Emma Reynolds. Emma is in the child and adolescent health area of interest in the program, and she joined our MSPH program with a Bachelor of Science from Fordham University with majors in both biological sciences and anthropology. Emma is going to present about disparities in receipt of contraceptive counseling by sexual minority status. So, oh, there you go, Emma. Take it away.
Thank you so much. Can you see my slides okay? Does that look all right?
Looks perfect.
Okay,
Yep.
awesome. Great. So hi, everybody. My name is Emma, and I will be talking today about queer youth and their contraceptive access, particularly disparities in receipt of contraceptive counseling and the quality of that counseling by sexual minority status. And my essay reader and advisor is Celia Karp. Okay, so a little bit of background. I think a lot of us on this call are familiar with barriers to contraceptive care. They are numerous and affect people all across the life course, all across socioeconomic status and race and ethnicity. And a lot of these barriers are also compounded when youth are experiencing or are a part of the LGBTQ community. And some of these can include disparate accessibility and quality of sexual and reproductive health resources. These are often targeted at heterosexual youth or heterosexual people in general, and so the quality for youth both at the school level and in online resources and at the physician level, at all of those levels, there's a different level of care and accessibility. There's also a lot of discomfort in disclosing identity to physicians. And on the other side of that, physicians also report discomfort in navigating these interactions with LGBTQ youth and LGBTQ patients. And this is a really big deal because 1 in 3 patients, the literature has posited, seeking reproductive care identify as a sexual minority, and at least in this study. And that's speaks to the scope at which this issue is relevant. And I think that there are a lot of assumptions that come into play when you think about giving care, particularly contraceptive care, to people under this umbrella of LGBTQ. And a lot of these assumptions aren't necessarily grounded in reality. One of them might be related to the type of sex that people are having and the type of risk that they're incurring in pregnancy. And I found this statistic really interesting, also from Everett et al., that 17% of lesbian identifying women and 83% of bisexual identifying women in their study had sex with a man in the past year. So just because somebody's identity, they might identify one way, that doesn't necessarily mean that that identifies all of the sex that they're having, even in a short term, but especially not in the longer term. And this is particularly relevant for youth who might be exploring their identity. And it's also relevant as our concept of gender is rapidly changing, and this it becomes more complicated too, right? Someone might be a lesbian with a female partner, and that partner might be trans and still have the capacity to get that person pregnant. So thinking about all of the different ways that pregnancy can happen and contraceptive need may be relevant, but might not be apparent in the way that we might be thinking. So my research question was really, given these realities, what are young sexual minority women, what are they experiencing when they're asking for contraceptive counseling? What are they receiving? How are they receiving it? And how can we make it better? So I did an analysis, secondary analysis of the Youth Reproductive Access Survey from Power to Decide. And they're an organization that focuses on reproductive rights activism and policy and research. They do a lot of great work. And they're based out of DC. And this survey in particular is an annual survey that is delivered to youth who identify as female and that are between the ages of 15 and 29. So really targeting that younger young adult demographic. And there were 1,203 respondents in 2024, which is the data set that I used. So this is my table one for this analysis, and I really wanted to think about a few things. So in the survey, there was a question that asked, did you receive contraceptive counseling? Yes or no, pretty black and white. And that's in the middle column here. You can see the people that responded yes to that question. And that was 440 people out of our 1,200 participants. And then after that, if they answered yes to that question, they were asked, how comfortable were you in having this conversation on a scale of 1 to 5? And of those 440, 346 reported low comfort level. So either very uncomfortable or uncomfortable in having this conversation with providers. Some other things of note, the participant population was primarily straight, heterosexual, and also was majority white. So those are important things to consider when thinking about our analysis. So in terms of my methods, I did this secondary analysis in 2 different ways. In terms of the first question, as binary variable, so I did a logistic regression and I had unadjusted and adjusted models, and those adjusted models were adjusted for age and race ethnicity. And then I also did an ordinal regression to really assess this scale of degree of comfort, and that was an adjusted model. And then I also broke it down into categories of a broad LGBTQ umbrella and compared to their heterosexual counterparts, just for ease, and also because our sample sizes get really small, but we'll talk a little bit about that. So some key takeaways from this analysis, as I mentioned, a pretty small amount of respondents reported having contraceptive counseling at their last physician visit. That was 36.6%. And then of those, again, 78.8% of respondents were uncomfortable or very uncomfortable discussing contraceptive with a provider. These are just descriptive statistics, but I think they really illuminate this problem with a lot of clarity. The statistically significant finding that I can report is that gay and lesbian women respondents did have lower odds of receiving contraceptive counseling, but there were no statistically significant differences among sexual minority groups in terms of comfort. So that low comfort is really just across the board. So again, based on these findings, sexual identity might impact the odds of counseling receipt, but these differences aren't carried over into comfort level among those who did receive counseling. And these findings are supported by current evidence base. It is not a novel finding that gay and lesbian women receive less contraceptive counseling, unfortunately, but it is a new finding in this younger age category. It's really only been explored in adult women specifically. So that's still interesting and exciting. There were several limitations. Again, my sample sizes got very, very small, especially looking at the comfort level across specific sexuality categories. And then we are focusing on female youth, so that does limit our discussion to sexual minorities. Because it was female identifying youth, there were transgender and other gender nonconforming participants on the survey. But again, the wording of the survey being targeted means that they were very few in number, and I couldn't really conclude them in analysis in any meaningful way. And just broadly, quantitative analysis doesn't always tell the whole story. So it's difficult to assess comfort without asking people, why were you uncomfortable? Or what led to this discomfort? What kind of experience have you had previously? So I think there's definitely room for that in the future. But there have been a lot of interesting qualitative studies that have gotten at some of these ideas. So going forward, my recommendations and things I think that can make a big difference in this area are better education for providers. So giving providers the tools to just understand what needs for sexually diverse populations might be, and also helping them be more comfortable with patients of diverse backgrounds. There's also a lot of potential for inclusion of sexual and gender minority patients in contraceptive programming and interventions that like are supposed to increase their access. And then again, I think that quantitative work is really important, and I really wanted to capture the scope of this problem. But I do think that further work that captures the narrative side of some of these findings could be really important and a really exciting next step for this work. Thank you so much for listening. That's all I have. And again, an especially big thank you to Celia Karp, who's my reader, and for Emma Carpenter. She helped me with the data side of things. So, and everybody else that's here, and my family, and all those things. I'm excited for your questions.
Great work, Emma. Thanks so much. I will open it up for questions now from the audience. I had one question and I may have just missed it. Could you talk a little bit more about the recruitment methods for the study?
Oh, yeah, absolutely. It's so it was a little confusing. It's based off of a system that's in place with they sampled adults, and then it was through this adult network that they were asked, do you have a young minor in your household? That's how they recruited the minors. Just do you have a minor in your household that wants to participate in this study? And then the adults were sampled um, through I'm missing, I can't remember the name of the way that they did it, but it was through I want to say like a company or something. It was nationally represented. I know that nationally representative, and household based. So reflects a lot of different backgrounds, a lot of different geographies. If I had all the time in the world, I would break it down by geographic location and all those things that we know are so important to contraceptive access. But you know, say
Thank
la vie.
Yeah, yeah. Yeah, I know conducting surveys in the US is difficult, and particularly conducting surveys with minors can be tricky. So interesting. Other questions from the audience? Do you want to maybe talk a little bit more about your recommendations, or I'm curious about your thoughts on just like the general state of like existing programs and providers and like the training that they're getting on this. What would you
Yeah.
recommend?
Absolutely. So I did a lot of literature searching, as you can imagine, as we all did. But I found a lot of reports that medical students just weren't feeling prepared in these patient interactions. And there's not a lot of specific curriculum that talks about these issues, and definitely not that is purposefully putting med students in contact with LGBTQ patients. So they're not getting this face time until they're farther along in their medical training. So I think that implementing that earlier on in the process would be a really great step. And I think a lot of medical schools are already doing that in a pretty serious way. So that's really great. And I'm not sure how you capture physicians that are already, have been practicing for a long while. I think that's a little bit trickier, but um, yeah, I was really shocked by that, and the what the literature had to say about physician discomfort and lack of preparedness. There's a lot of really great work out there that talks about that. So I think that's a really important step. Um, yeah, I think I want to
Yeah,
see
yeah.
what.
There's Anna
Yeah.
asked in the chat, first off, awesome work. And she would like to know about your thoughts on recommendations on how and why of contraceptive counseling. Should everyone get it at baseline? Should it be determined based on sex behaviors? How do providers ask about sex behaviors?
I think that's such a great question, right? Because like just asking about sex behaviors just asking about partners doesn't capture it fully, and then asking about sex behaviors might not capture it fully. So I think there could be an argument for, more in-depth conversation, asking, are you having sex with um, somebody who has a penis or something like that? I know parts-based discussion is something that people talk about in the LGBTQ spaces, but I think I think that a really important step in all of this is also just normalizing these conversations and increasing awareness of what all of these different identities can mean, and what the sex that people who identify in these groups, what that might entail, I think is really an important step. And um, I think that increasing comfort level across the board, and both in asking those questions and in sharing what kind of sex you're having and what your partner, um, you know, who you're partnered with, and all of those things, it's really important too. So increasing the comfort level that people have with their providers. And I think that's a very big suggestion. It's a difficult thing to tackle, but I think that just being able to have these conversations and allow for people to ask the questions that are specific to their experiences is really important. So I think that it starts with honest conversation, and I think that it should probably be at baseline that people are receiving contraceptive care. And I think, again, in young patient populations, I think it's important to have the knowledge, the background knowledge of what your options are, and what is available to you should you want it, even if you might not need it right now, or you might not need it ever. It's still important to know that it's out there. So I think that, yeah, having more honest and open conversations and empowering providers and patients alike to have those conversations is a very big but important first step.
Thanks, Emma. Yeah, and I think you did a great job of demonstrating that there really is a lack of comfort. And so it's important both for the things that you're discussing today, but just like, more broadly, I think would have a lot of positive implications. So thanks
Yeah,
so much, Emma.
thank you.
Thanks. So now we're going to turn to our fourth presentation. Isabella Bonnewit is up next. She is in the child and adolescent health area of interest, and has a Bachelor of Science from the University of Michigan with majors both in biology, health, and society, as well as social theory and practice. And today, Isabella is going to talk about hardship and well-being in parentally bereaved adolescents. Hopefully, you are better at pronouncing that than I am.
Thank you so much, Sally. I'm really excited to share more about my master's essay with you all today. So to give a bit more background about parentally bereaved youth, over 5 million children in the United States will experience the death of a parent by the time that they're age 18. And the odds of parental bereavement are not the same for all youth. Black and African American children are more likely to experience parental bereavement than children in any other racial group. In addition, children who live in households with lower socioeconomic status are at a greater risk for experiencing parental bereavement. Among young adults, those who experienced parental bereavement as a child are more likely to report adverse childhood experiences and less likely to report positive childhood experiences. And we know that those PCEs are really important for well-being later in life. What I saw in the literature that within group differences of bereavement, of parental bereavement, were less explored. And I wondered, well, if we can look at various factors and differences between youth who are parentally bereaved, how can that help us understand how to promote well-being amongst bereaved youth? And so one factor that I was really interested in looking at for my master's essay was material hardship. And my hypothesis for this research question was that among bereaved youth, those who experienced less material hardship, that would be associated with increased well-being. And so to approach this research question, I used data from the Future of Families and Child Wellbeing study. So this study is a longitudinal birth cohort study that includes approximately 5,000 children who were born from 1998 to 2000. And these are children who were born in major US urban areas. The study oversampled non-marital births, and data that I'll be using for this research was used when youth were age 1, age 5, age 9, and age 15. So I used a subset of the Future of Families data of 410 youth who had experienced parental bereavement at some point before their age 15 visit. The outcome that I looked at was well-being, and this was measured with the EPIC measure of well-being, which is a measure that includes these 5 subscales, and those 5 subscales add up to the total measure. The exposure that I looked at was material hardship. So material hardship was assessed at each of these time points. One example of material hardship was like, was your phone disconnected in the past year? I also looked at cumulative hardship. So I wanted to understand the effect of the total number of hardship a youth had experienced through age 15. I used t-tests and ordinary least squared regression models to assess these associations. And first, I just want to give you a picture of my study sample characteristics. You can see that about 2/3 of the youth lived in a household where the income was above the federal poverty line. This sample was really racially diverse. About 14% of the bereaved youth in my sample identified as white, about like half of the sample identified as non-Hispanic Black, and about 18% of the sample was Hispanic. At the bottom, you can see the EPIC scale scores. Those are on a range from 0 to 4. And as you can see, the bereaved youth in this sample reported really relatively high levels of well-being. Here is the descriptive data of the material hardship. This was reported by the parents of the youth. The most common, as you can see from this heat map, the most common material hardships reported were borrowing money from family or friends and non-payment of utility bills. And to give you a sense of the individual data, at year 1, about 52% of the families reported at least one material hardship. And at year 15, it was pretty similar. About 48% of the families reported at least one material hardship. So here now for the inferential statistics, we found that when we compared youth who had experienced no material hardship at year 15 with those who had experienced any material hardship, we actually saw that those who had experienced any material hardship had self-reported higher optimism and engagement. But these findings should be interpreted in light of the poor subscale reliability. So those smaller subscales didn't have good internal consistency. And so for the remainder of the analysis, I just looked at the overall EPIC scale. And in those adjusted models where I looked at the association of childhood material hardship at each time point, controlling for demographic variables, we found that it did not predict well-being in late adolescence at year 15, nor did cumulative hardship. So contrary to my hypothesis, material hardship and well-being were not significantly associated in this sample of bereaved youth. And if there's one thing I want you to remember today, it's that this doesn't suggest that hardship is unimportant during childhood development. The null association actually really highlights the importance of protective processes for bereaved youth and their well-being. So a couple possible explanations for these findings is that, hey, on the family level, families might have mobilized support, drawn on extended family or social services in order to mitigate or to buffer the impact of material hardship on well-being. And that's supported by this idea that the most common material hardship we saw was borrowing money from family or friends. That might be a good thing. That shows that bereaved families have these active informal safety nets. We also saw in our data that bereaved adolescents self-reported pretty high rates of connectedness. And we know that those peer connections are really important for well-being outcomes for bereaved youth. And that was across the board. So even youth who were experiencing material hardship also reported high rates of connectedness. And to continue just like comparing these, like situating these findings in the literature, there was actually a study that was done with the Future of Families data, with the whole data set, so bereaved and non-bereaved youth, that looked at material hardship and anxiety and depression, and they found that those were statistically significantly related. But in this study, in this subsample, we didn't observe that parallel impact that you might expect to see with our outcome of well-being. The literature really emphasizes the role of the surviving parent for bereaved youth. Positive parenting has been shown to mitigate health consequences. Parents who facilitate the grieving process during childhood have children that have higher general functioning as adults. And so I think that really underscores the role of protective processes for bereaved youth, especially those who might experience material hardships in their lives. I'll quickly highlight a few of the limitations. One is that this is a secondary data analysis, and there's limited data available regarding parental bereavement, especially details surrounding parental bereavement, like the cause of death, the child's age at death. We weren't really able to like systematically add those to the analysis. Also, the low reliability of the EPIC well-being scale shows that EPIC might not be the best measure of well-being for this study population. What well-being looks like for non-bereaved youth might be very different than how well-being would look for bereaved youth. And so it's a limitation of this study, and I think I would recommend that the EPIC subscale be validated for use in this population in the future. So that kind of takes us into future recommendations. I think future survey data collection on bereaved youth should definitely include some of those characteristics that I mentioned of bereavement. Another one that's potentially really important for these models is household composition. When we're doing survey data collection on bereaved youth, we don't necessarily know the relationship between youth and the parent. And so adding these characteristics to models is really important. Also, I just really want to highlight the importance of qualitative research in this field of bereaved youth and their well-being. Qualitative research can help researchers understand these causal mechanisms and the interrelationships that I brought up today between material hardship and well-being and bereavement. And I think that my reader, Dr. Powell, is going to continue exploring these topics in her qualitative research, which will be really exciting to see. I want to acknowledge a bunch of people for all their support. Dr. Powell and Dr. Woodward, thank you so much for all your insights and mentorship on this project. I want to thank the participants of the Future Families Study and their contributions and their time. I want to thank my friends and family, my support system, folks on the call today. I couldn't have done it without you. And I want to thank my dad, who would definitely be very proud of me. When I was a teenager, my dad passed away, and so it's made this work very meaningful for me, and it's been a really fun project to work on and just like interesting and really special. So yeah, thank you so much for listening. What are your questions?
Great job, Isabella. Thanks so much for sharing and great work.
Thank you, Sally.
Questions from the audience? Maybe I'll ask, or Anna, do you think that there was anything about your sample in particular that might explain some of your differences you saw in your findings compared to the literature?
I think that the sample is large enough and it's a nationally representative sample. Well, it's a national sample. So I don't think that there's necessarily anything about my sample that might explain some of the differences. I do think that that measure of well-being does need to be like tested and validated better with bereaved youth. To me, I think like that might be the biggest difference maker. Emmy, I see you have a question.
Yeah, this is going to sound kind of indelicate, but I know the Fragile Family Study oversamples non-marital families, right? And so children of non-marital. Do you have any information on sort of the closeness of the child to the person who passed away. Again, I don't mean to make it sound like, well, then it doesn't
No,
matter. But
that's a
that
great
is
question.
highly salient, right? And especially if it happened very early and so on. So, any thoughts on that?
Yeah, it's a great question, and we don't have that data. And I think that's what makes survey data on bereavement really challenging. It's hard to capture grief with survey questions, and of course, you want to be sensitive. And so that's why I think that the qualitative approach is important. But at the same time, the quantitative approach allows us to make these like bigger inferences. And so,
yeah, I mean, it is. I mean, the FROC measure, as you say, is flawed, but it does suggest okay, there's considerable resilience, is what you're showing, and of course, again, grief is complicated, and if a lack of close relationship can be a real impetus for grief too. So it's sort of messy here, but really interesting issue. It's actually one I've been interested in a long time myself. So I'm really interested. Great to hear your findings.
thank you
And
so
you're
much.
focusing on this.
Isabella, maybe I'll ask one more question. I'm curious about the process of, you had your hypothesis and then your findings didn't support that hypothesis. I think you had a really great research team. Could you talk a little bit about the process of like trying to figure out what was going on, and what that was like?
Yeah, it's funny when you do the statistical analysis and it's not what you expect. Um, but yeah, it was just a lot of back and forth. And I think that Terry gave me great advice, which was like, it's what the data is saying. Because I was like, oh, maybe if I look at this, maybe if I look at this. And we're like, hey, this is a statement in itself, even though these findings are null. So yeah, that was a great lesson.
Great. Thanks so much. Great work. We'll go on to our final presentation of the day. Shubhi Tyagi is in the maternal, fetal, and perinatal health area of interest, and she came to our PFRH MSPH program at the Bachelor's of Arts from the University of Illinois Chicago with a major in applied psychology. So, Shubhi, I will hand it over to you.
Thank you, Sally. Good afternoon, everyone. Today, I'll be presenting my thesis examining whether expectant mothers and fathers are aligned in their perception of fathers' caregiving expectations during pregnancy. My interest in this topic is deeply personal. Growing up, my relationship with my own father shaped how I understood what it means to be present. To show up for a child before and after birth, I saw firsthand how much it matters when a father is invested and how much is missed when he isn't. That planted the seed for this question. We know from the literature that fathers play a critical role in infant health and family functioning, and that early on engagement during pregnancy lays the foundation for sustained involvement after birth. Yet research on paternal caregiving largely focused postnatally, and most studies have relied on only one parent's report. The limited work examining alignment between parents tells us something really important. McBride and colleagues in 2005 found that after birth, fathers reported significantly greater involvement in planning and responsibility tasks than mothers attributed to them. And Fagan and Barnett in 2003 showed that mothers' beliefs about fathers' role was associated with how much fathers actually participated in parenting. And Redshaw and Henderson in 2013 documented that fathers' presence at antenatal appointments and birth, but none of these studies assessed alignment between both partners' perceptions of fathers' prenatal caregiving expectations. This is the gap the study addresses. Caregiving is a dyadic process. If a mother and father enter parenthood with misaligned expectations, that matters for how caregiving unfolds. Most studies ask only one person. I wanted to know, are the both partners on the same page? And if not, where do the gaps emerge? So the two objectives for the study were first one was describing what mothers perceive about their partner's caregiving readiness, a perspective largely absent from the prenatal literature. And second, examining alignment between mothers and fathers across three constructs: parenting self-efficacy, infant care self-efficacy, and infant care behavioral intentions. And then this data came from the baseline survey of Text for Fathers study, which is a text-based pilot intervention to support expectant fathers' engagement, led by Dr. Eric Marcel. We recruited from one urban mid-Atlantic maternity clinic via social media, a dyadic study, so every analysis compares actual partners. Of 163 eligible dyads, 97 completed baseline procedures. Fathers needed less than a college degree, a proxy for lower SES, targeting a population with documented gaps in parenting support. Both partners completed the same validated scales independently, fathers rating themselves and then mothers rating the father. Negative mean differences indicated mothers rated fathers higher than fathers rated themselves. And then we used 3 validated questionnaires. First is the Parenting Sense of Competence Scale, the PSOC, which had 15 questions asking how confident a person feels about being a parent overall. Things like whether they feel like they have skills to be a good father, whether they expect parenting to be emotionally rewarding, and whether they feel in control when parenting challenges come up. The second is KPCS, the 10 questions focused on confidence with hands-on day-to-day tasks of caring for the baby, like feeding, soothing, knowing what to do when the baby cries, handling a minor illness. And the third is father engagement scale, 11 questions asking how often a father plans to do specific caregiving activities after birth. Things like feeding, reading, playing, putting the baby to sleep. Both partners answered the same questions independently, and fathers about themselves and mothers about their partner. On the analysis side, we used paired t-tests to compare responses within each actual couple. The key metric is the within dyad mean difference, mother score minus father score, a negative value meaning mothers rated fathers higher than fathers rated themselves. A positive value means the reverse. And we report 95% confidence intervals and Cohen-D's for the effect size as well. Oops. For the sample characteristics, predominantly a non-Hispanic Black sample, most fathers and mothers in their 30s, 98% of the couples romantically involved or married, 85% cohabiting, 68% of the fathers had a high school diploma or less, and 75% were employed, and notably 45% were first-time fathers, making prenatal expectations especially salient for nearly half of the sample. Starting with the parenting self-efficacy for the key findings, overall mothers rated fathers' parenting self-efficacy significantly higher than the fathers rated themselves. Mean difference of negative 2.3 on a 6-point scale, and the efficacy and interest subdomains were aligned, but 2 showed meaningful gaps. In satisfaction, whether parenting will feel emotionally rewarding, fathers scored lower, with the most striking item being not knowing whether you're doing a good or a bad job. Fathers scored nearly a full point lower than mothers. In perceived control of confidence to manage parenting challenges, fathers scored 0.65 points lower. This was the only finding that persisted after adjusting for all the background characteristics, our most robust signal. So the takeaway from this, fathers privately doubt their readiness as parents in ways the partners might not be able to see, and mothers saw their partners as more capable than fathers saw themselves. For infant care self-efficacy, task-specific confidence like feeding, soothing, sleep, strong alignment across the board, no significant overall difference. Fathers rated themselves slightly higher on 2 items, sleep routine and minor illness management, concrete and plannable tasks. For the behavioral intentions, a strong overall alignment, though fathers trended slightly higher than the mothers expected. The caregiver and play subdomain reached significance, so fathers reported higher intentions around direct caregiving and feeding than mothers anticipated. This may reflect fathers actively imagining a hands-on role. The headline is that on the task-specific dimensions, these couples are fully on the same page. These couples are largely aligned before birth, which is meaningful context for postnatal discrepancies documented in the prior work, particularly McBride's finding that fathers reported more involvement in planning tasks than mothers attributed. Our data suggests that gap may not start prenatally, it may emerge as roles are negotiated after birth. Future longitudinal work following these dyads is essential to identify when and why these perspectives diverge. The key exception is parenting self-efficacy, particularly perceived control. Fathers enter pregnancy with lower confidence in their ability to manage the challenges of the parenting roles than mothers perceive them to have. And because mothers rated fathers higher than fathers rated themselves, there is a gap in how each partner is experiencing that dimension. Task specific skills are observable and plannable together. Confidence in yourself as a parent is internal. An identity level belief that may simply be harder for a partner to accurately gauge. From the outside, the high aligned behavioral intentions are also consistent with the theory of planned behavior. These fathers are entering parenthood with deliberate attitude driven commitments that may predict postnatal engagement. As for the limitations, this was an urban single site sample. Findings should not be broadly generalized. Only fathers' caregiving expectations were assessed, not mother's own. Cross-sectional cannot track how alignment evolves. Sample size is limited. Advanced dyadic model. The strengths included among the first to examine prenatal caregiving alignment using a dyadic design with a paired partner data, giving precision single reporter studies cannot match. And then also addresses an underserved population with documented unmet needs. As for the implications for clinicians and programs, the prenatal period is a window, creating structured space for couples to surface expectations before roles are enacted has real value. Fagan's 2008 pre-birth co-parenting intervention showed that this improved parenting alliance and parenting engagement after birth. For fathers specifically, the sample challenges deficit assumptions. This gap wasn't in commitment, it wasn't in how they feel about their readiness. Programs should target perceived control and satisfaction and not just task skills. For research following these dyads longitudinally to understand whether prenatal alignment predicts how caregiving actually unfolds postnatally. And then lastly, I would like to close by thanking my advisor, Dr. Eric Marcel, for his mentorship throughout this project. The broader study team, Dr. Radha Ranjan, Dr. Catherine, and Dr. Mo as well. And most importantly, the 97 couples who gave their time. And all my friends who are on this call, my parents, and yeah, thank you. Happy to take any questions now.
Great work. Thank you so much for sharing. And what questions do people have? So your last recommendation was about research and continuing, maybe continuing into parenthood. And are there plans for that?
That's a great question. I don't know if there are plans.
Maybe not a
should
question for
ask
you, but yeah, for the
probably ask Dr. Eric Marcel if he has plans, but that would be a great strategy. Again, just highlighting how if we could have done this study again, making sure we also incorporated the maternal caregiving expectation scale as well. That would have been a good approach, but that's a great idea for future research. Yeah.
Thanks. And I see a hand. Do you want to come off of mute, Ayushka?
Hi, Shubhi. I loved your presentation and the personal connection at the beginning. I was just curious to hear a little bit more about your experience working on this project, as well as if there was one particular finding that stood out to you.
Yeah, thank you, Ayushka. That's a great question. I was actually working with this study since I started at Hopkins. So like I've been working with the study for about 2 years. shout out to Dr. Eric. He was amazing. He has been amazing. It's been a long journey, but it was an amazing one. And then about your most surprising finding, honestly, there were like two things that stood out to me. The most surprising was the parenting self-efficacy one, which specifically perceived control. We expected some differences between partners, but what stood out the most was that mothers consistently rated fathers' confidence higher than the fathers rated themselves, and then that gap held up even after adjusting for background characteristics. So it suggested fathers are working through uncertainty about their parenting role in ways that aren't like fully reflected in how their partners perceive them. And then on the flip side, the strong alignment in behavioral intentions was also notable. These fathers came in with high shared expectations of involvement, which also challenges the assumptions about this underserved population.
Hannah?
Again, thank you so much, Shubhi, for this really great presentation. I had a quick question. So, why did you examine mothers' perception of fathers rather than just the self-reports of fathers?
Yeah, that's a great question. Parenting is inherently relational and occurs within a couple dynamic. Most prior studies only assess one parent's perspective, which limits understanding of like couple level dynamics, including both perspectives provide more like complete ecological valid view of caregiving expectations. So this dyadic comparison allowed us to assess that actual alignment rather than assume one person's perspective. And yeah, just Fagan and Barnett. I'm just thinking of that, showed that back in 2003, like if we only ask one partner, we're just assuming their view reflects the shared reality, which our data shows that it wasn't always true. Yeah.
Great. Well, thank you. Thank you so much. I'm going to give a huge round of applause to all five of our presenters today. Excellent work. I love the master's essay presentations. I always learn so much, and really great to hear about a variety of topics today, and so exciting to hear what you all are so passionate about. So thanks for teaching us. Thanks for all the questions from the audience. And I'll just do one final plug for our final round of presentations next Wednesday. So thanks everybody for being here, and hope to see you next week. And great job,
Thank you
everybody.
all. It's always so rewarding and wonderful to see these presentations. So
Great work.
great work.